Millions of people over 60 are being treated for the wrong number, and the treatment itself may be doing more damage than the condition it's supposed to fix. There is a specific blood pressure target that a 30-year ICU veteran knows is right for your age, and it is not the one your doctor is probably chasing. Not 120 over 80, not even close. And when older adults are pushed below a certain threshold, something dangerous happens inside the brain and the heart that most physicians never connect to the medication. Stay with me because what I'm about to share comes from 30 years of watching what actually happens to people's bodies, not in a textbook, but in an intensive care unit where the consequences are impossible to ignore. Before we go any further, I need to tell you about the number one revelation in today's video. There is a pressure range, a specific window, that research now shows is actually protective for adults over 60. Not just acceptable, protective. A landmark study found that older adults maintained in this range had significantly lower rates of stroke, kidney failure, and cardiovascular events than those pushed into the so-called normal zone. And yet almost no one over 60 is told about it. Stay with me until the end, because understanding this window could be the most important health decision you make this year. I'm Dr. Margaret Ellison, a physician specialized in senior health with over 15 years of dedicated clinical experience. I've worked alongside nurses, cardiologists, and emergency teams, treating hundreds of patients over 60 in crisis situations related to blood pressure mismanagement. What I am about to share goes against the standard script most doctors follow in a 7-minute appointment. But I have seen it with my own eyes, patient after patient, and I refuse to stay silent any longer. If this information seems valuable already, hit that like button right now, and let's get into it. Here is what most people over 60 are never told. The number 120 over 80 was established largely through studies done on younger populations. When researchers began looking specifically at older adults, the picture changed dramatically. After 60, the arteries naturally stiffen. The heart has to work harder to push blood through a less flexible system. That slight increase in pressure is not always a malfunction. In many cases, it is the body compensating intelligently to make sure the brain, the kidneys, and the extremities still receive adequate blood flow. When we aggressively lower that pressure in an older adult, we can inadvertently starve those same organs. The brain, which requires constant, uninterrupted perfusion, is the most vulnerable. Researchers call it hypoperfusion. You call it dizziness, mental fog, fatigue, balance problems, and falls. And here is what terrifies me most. Many of those symptoms get attributed to aging. Nobody connects them to the blood pressure medication that was prescribed with the best intentions 3 months earlier. Here's what's happening inside your body right now if you're over 60 and being treated to reach 120 over 80. Your vessels have adapted over decades. They have developed a new baseline. Dropping suddenly below that baseline, even to what a textbook calls normal, can trigger a cascade: reduced oxygen to the brain, increased risk of falling, potential kidney stress, and in some cases, a paradoxical increase in cardiovascular events. The medical community has known about this nuance for decades, yet the standard prescription pad hasn't always caught up. Before we continue, I'm curious. How old are you? In your 60s, 70s, maybe beyond? If your doctor has ever told you that your blood pressure is too high and immediately reached for a prescription pad without discussing your specific age-related targets, type hi in the comments below. Let's see how many of us share this experience. So let me walk you through what the research actually says and what a seasoned ICU nurse and senior health specialist know that most general practitioners don't prioritize in a short appointment. I'm going to take you through 7 critical things you need to understand about blood pressure after 60, ranked from the least urgent to the most important revelation at the end. Pay attention because each piece builds on the last. Number 7. The old 120 over 80 target was not designed with your age group in mind. The guideline of 120 over 80 as the gold standard of healthy blood pressure has been ingrained in public health messaging for so long that most people treat it like a law of nature. It is not. It is a statistical benchmark derived primarily from studies that skewed toward younger, middle-aged adults. When the American College of Cardiology and the American Heart Association updated their guidelines in recent years, they acknowledged the complexity of treating older adults. particularly those over 65, who may have naturally higher baseline pressures without the associated organ damage that younger patients experience at those same numbers. The distinction that matters is between primary hypertension and what some researchers describe as physiologically adaptive elevated pressure in older age. The first requires treatment. The second may require monitoring and lifestyle intervention rather than aggressive pharmaceutical lowering. The problem is that both often get treated the same way, in a rushed clinical setting. A study published in the Journal of the American Medical Association found that in adults over 65, aggressive blood pressure lowering was associated with a higher incidence of adverse kidney events and orthostatic hypotension, which is the dangerous drop in pressure that occurs when you stand up. That dizziness you feel when you rise from a chair too quickly, that is orthostatic hypotension. And in older adults, that is how fractures happen. Pro tip: the next time you have your blood pressure measured, ask your doctor specifically what target range they are aiming for and why. If they say 120 over 80 without any discussion of your age, your kidney function, your medication interactions, or your fall history, that conversation is not finished. Number 6, your diastolic number matters more than you think, and most people over 60 are watching the wrong one. When your doctor reads your blood pressure as 135 over 82, the 135 is the systolic pressure, the force when your heart contracts. The 82 is the diastolic pressure, the force when your heart is at rest between beats. Most public health messaging has focused heavily on systolic numbers. And while elevated systolic pressure is a real concern, in older adults, the diastolic number carries its own set of critical warnings that often get overlooked. In older patients, there is a phenomenon called isolated systolic hypertension, where the systolic climbs while the diastolic remains normal or even drops. This widening gap called pulse pressure is actually a marker of arterial stiffness. An elevated pulse pressure in a senior is not simply high blood pressure. It is a signal that the vessel walls have lost elasticity. Treating it with the same medications used for classic hypertension in a 40-year-old can drive the diastolic dangerously low, reducing the perfusion pressure that keeps coronary arteries filled during the heart's resting phase. Research published in Frontiers in Aging found that adults over 70 with diastolic pressure below 70 millimeters of mercury had a statistically significant increased risk of cardiac events, even when their systolic numbers appeared controlled. The heart needs that resting pressure. Remove it, and you are working against the organ you are trying to protect. Here's the kicker. Many seniors on standard antihypertensive medications end up with a diastolic that goes too low precisely because the drug was calibrated for systolic reduction. Nobody checks the bottom number with the same attention. Now you will. Number 5, medication timing is silently sabotaging your nights and your mornings. Most blood pressure medications are prescribed to be taken in the morning. It is a convenient default, but the body does not experience blood pressure as a flat, consistent number throughout the day. Pressure follows a circadian rhythm. It dips naturally during sleep, rises sharply in the early morning hours, an event known as the morning surge, and fluctuates in response to activity, meals, stress, and position throughout the day. For adults over 60, the morning surge is particularly relevant. Between roughly 6 and 10 in the morning, blood pressure rises significantly as the body transitions from rest to activity. Cortisol increases, heart rate climbs, and vascular resistance shifts. This is the window when the majority of heart attacks and strokes occur in older adults. Not coincidentally, it is also the window when a medication taken the previous morning may be at its lowest effective concentration. A study in the Journal of Clinical Nutrition and several circadian pharmacology analyses have shown that evening dosing of certain antihypertensive medications, particularly those with longer half-lives, provided better nighttime pressure control and reduced the amplitude of the dangerous morning surge compared to morning dosing. Yet the default prescription, in most practices, remains unchanged. This isn't about stopping medication. This is about asking your doctor one specific question. Given my age and my blood pressure pattern throughout the day, is there a better time for me to take this? Before we continue, if you're finding this helpful, please hit like and subscribe so you won't miss the practical health information we share every week. Number 4, White coat syndrome is being misused to diagnose millions of seniors. Here's something that happens in clinics and doctors' offices every single day. A patient over 60 arrives, slightly anxious, perhaps rushed from traffic, perhaps nervous about test results. A cuff is placed on their arm, the number comes back elevated, and a prescription is considered or written. White coat hypertension, the temporary rise in blood pressure caused by the stress of a clinical encounter, is well documented. Studies suggest it occurs in anywhere from 15 to 30% of patients, and rates are higher in older adults who may experience more health anxiety. The problem is that this transient elevation is being captured in a snapshot measurement and used to make long-term pharmaceutical decisions. The gold standard for blood pressure assessment in older adults is ambulatory blood pressure monitoring, a portable device worn for 24 hours that captures readings across an entire day and night in the context of real life. This gives a far more accurate picture than 3 readings taken in a waiting room. Research in the New England Journal of Medicine demonstrated that ambulatory monitoring significantly reduced unnecessary prescriptions and improved targeting of treatment in older populations. I remember Patricia, a 71-year-old retired librarian from Minneapolis. She came to me having been placed on 2 blood pressure medications after repeated clinic readings in the high 140s/85. She complained of constant fatigue, difficulty concentrating, and had fallen once in her kitchen. She was convinced she was simply getting old. I ordered ambulatory monitoring. Her average blood pressure over 24 hours was 128/76. Her clinic readings were elevated entirely due to anticipatory anxiety. Her fatigue, her cognitive fog, her fall risk, they were not aging. They were the physiological consequence of a diastolic being pushed too low by medications she did not need. She told me, and I will never forget her words, "Doctor, I thought my brain was going. I thought I was losing myself. You gave me back my life." We carefully withdrew her medications under close supervision. Within 6 weeks, her energy returned. She went back to walking 3 miles every morning. That was not a miracle. That was the body being allowed to function at its own intelligent baseline. If you believe that ambulatory monitoring should be standard before any blood pressure medication is prescribed for a senior, type yes in the comments. If you're skeptical or your doctor has never mentioned it, type 0. Your response helps others see they are not alone. Number 3. Salt is not the villain it has been made out to be for people over 60 specifically. For decades, the public health message has been uniform and uncompromising: reduce salt, lower blood pressure, protect your heart. The science behind this message is real, but it is incomplete. The salt-blood pressure relationship is highly variable, and in older adults specifically, the picture is considerably more nuanced than a single dietary recommendation can capture. Approximately 50 to 60% of hypertensive patients are what researchers call salt-sensitive, meaning their blood pressure rises meaningfully in response to sodium intake. The remaining 40 to 50% are salt-resistant, meaning dietary sodium has minimal effect on their readings. Among adults over 65, the distribution shifts somewhat, with a higher proportion being salt-sensitive, but a significant minority still do not respond to sodium restriction with meaningful pressure reduction. What does change consistently in older adults with sodium restriction is risk of hyponatremia, low blood sodium, which in seniors is associated with confusion, falls, loss of muscle mass, and in severe cases, seizures and death. A study published in Nutrients found that aggressive sodium restriction in adults over 70 was linked to increased all-cause mortality and adverse metabolic outcomes, particularly in those who were also taking diuretic medications. This is not a recommendation to pour salt freely over every meal. It is a recommendation to have an individualized conversation with your physician about whether sodium restriction is actually indicated for you specifically, based on your sensitivity, your kidney function, your current medications, and your overall nutritional status. I remember William, a 78-year-old retired engineer from Atlanta. He had been told by multiple doctors to eliminate salt. He followed the advice rigidly for 2 years. He came to me complaining of profound fatigue, muscle cramps every night, and a mental slowness he described as thinking through cotton. His sodium levels were in the low normal range, borderline hyponatremia. His blood pressure had not changed meaningfully. He had sacrificed flavor, satisfaction, and 2 years of quality of life for an intervention that was not even working for his physiology. We corrected his sodium intake carefully. His cramps resolved within 2 weeks. His energy returned. He said, "I didn't know food could taste like something again." Your body is not a textbook. It is a specific, individual system. Treat it that way. Now I want to hear from you. Have you been told to restrict salt strictly, only to feel worse rather than better? Share your experience in the comments. I read every single one. Number 2, the blood pressure medications most commonly prescribed for seniors carry risks that are rarely discussed in the appointment. I want to be very clear before this section. I am not telling you to stop your medication. I am telling you that you deserve complete information about what you are taking, and that information is not always offered in a standard clinical encounter. The most commonly prescribed antihypertensives for older adults fall into several categories: ACE inhibitors, ARBs, calcium channel blockers, beta blockers, and thiazide diuretics. Each class has a specific mechanism, specific benefits, and specific risks that become more pronounced in older populations. Beta blockers, widely used and often appropriate, can cause fatigue, exercise intolerance, and, in some older adults, a blunting of the cardiovascular response to exertion that reduces functional capacity and independence. Research in the Journal of Applied Physiology found that older adults on beta blockers showed significantly reduced aerobic capacity and muscle oxygenation during moderate activity compared to age-matched controls. Thiazide diuretics, the go-to first line for many cases, can deplete magnesium and potassium at rates that accelerate muscle cramps, cardiac arrhythmias, and bone density loss. Studies show that even mild diuretic-induced magnesium depletion contributes to nighttime leg cramps, a complaint extraordinarily common in older adults that is almost never connected by either patient or physician to the blood pressure pill they take every morning. Calcium channel blockers, generally well tolerated, can cause ankle swelling that is frequently misattributed to heart failure or venous insufficiency, leading to further prescriptions for conditions that are pharmacological side effects, not independent diseases. ACE inhibitors and ARBs carry real risks of acute kidney injury in patients with undiagnosed renal artery stenosis, a condition more prevalent in older adults with widespread atherosclerosis and often clinically silent until a medication triggers a crisis. What all of these classes share is that their standard dosing was largely derived from middle-aged adult trials. The physiological differences in older adults, reduced kidney clearance, altered drug metabolism, different receptor sensitivity, mean that standard doses frequently represent overdosing in a senior body. Ask your doctor, is this medication and this specific dose designed with my age group in mind? What side effects specifically are more common in adults over 65? Are we monitoring my kidney function and electrolytes regularly? That is not a confrontational question. It is your right. Before we continue with the most important revelation in this video, I want to make a quick request. If what you've heard so far seems valuable, I'm asking for 2 simple things. First, subscribe to this channel. My mission is to provide clear, straight-shooting health information so you can make the best decisions for your own body. Second, share this video. Think about your parents, your grandparents, your friends. A simple click can start a conversation that could genuinely change a life. And now, number 1. The right blood pressure target after 60 is not a single number. It is a personalized range, and knowing yours could be the difference between thriving and declining. This is what 30 years in an intensive care unit teaches you. Not what the textbooks say, what actually happens to people. And what actually happens is this. The patients who do best in older age are not the ones whose numbers match a young adult reference chart. They are the ones whose pressure is optimized for their individual vascular system. The research has been building for years. The landmark SPRINT trial initially suggested that more aggressive pressure lowering improved outcomes, but SPRINT excluded adults over 75 with multiple comorbidities, which is precisely the population most commonly being treated in real clinical practice. The HYVET trial, which specifically studied adults over 80, used more conservative targets and still showed benefit, while noting that overly aggressive treatment was associated with harm in the oldest patients. The emerging consensus among geriatric medicine specialists is this. For adults between 60 and 70, a systolic target of 130 to 140 may be appropriate depending on individual cardiovascular risk. For adults between 70 and 80, a target of 140 to 150 systolic is often optimal, particularly in the presence of orthostatic hypotension, cognitive vulnerability, or fall risk. For adults over 80, guidelines from the European Society of Hypertension suggest that targets above 150 systolic may be entirely acceptable and preferable to aggressive lowering. These are not numbers I'm inventing. They are from published consensus guidelines that exist in the medical literature and are simply not making it into enough clinical conversations. Here is the most important thing I can tell you. Your blood pressure target should be determined by your specific age, your kidney function, your fall history, your cognitive status, your other medications, and your quality of life goals, not by a number on a poster in a waiting room. I remember Dorothy, a remarkable 83-year-old woman from Boston, a retired school teacher, sharp, funny, independent. She came to me after being hospitalized following a fall in her bathroom. Her daughter was terrified. Dorothy was on 3 blood pressure medications, targeting a systolic below 130. Her home readings were consistently in the low 120s. She was proud of her numbers. She also had dizziness every morning, struggled to walk to her mailbox, and had stopped accepting dinner invitations because she was afraid to stand up from a restaurant table too quickly. When we reviewed her case with a geriatric lens and adjusted her treatment to a safer, age-appropriate target of 140 to 145 systolic, under very careful supervision and with her physician's agreement, something extraordinary happened within 3 weeks. Her morning dizziness resolved. She walked a mile without stopping. She accepted a dinner invitation and danced at her granddaughter's birthday party for the first time in 2 years. She called my office and said, "I feel like someone turned the lights back on. I thought I was just old. I wasn't old. I was being overtreated." This is not a miracle. This is an 83-year-old woman getting what her body actually needed, and you deserve the same. Now, let me tell you exactly how to implement what you've learned today. Start this week, not next month. This week. Your first action is to purchase a validated home blood pressure monitor, not a wrist device, a proper upper arm cuff. Take your blood pressure at the same time each morning, before medication if applicable, after 5 minutes of sitting quietly, twice in a row, and average the 2 readings. Record every measurement in a notebook or your phone for 2 weeks. This gives you real data about your actual pattern, not a single anxious clinic reading. Your second action is to write down 3 questions to bring to your next appointment. First, given my age, what is the specific systolic and diastolic target range you are aiming for me personally? Second, am I a candidate for ambulatory blood pressure monitoring before any medication changes? Third, are there any electrolytes or kidney markers we should be monitoring given my current medications? Your third action is to become aware of orthostatic symptoms. Every time you stand up, pause for 3 seconds. If you feel lightheaded, sit back down and time how long it takes to resolve. If it takes more than 30 seconds, or if it is happening daily, bring that specific information to your physician. Orthostatic hypotension in seniors is not a minor nuisance. It is a mechanism of falls, fractures, hospitalizations, and sometimes death. Do not make these critical errors. First, do not stop any blood pressure medication without your physician's involvement. Sudden withdrawal of certain antihypertensives can cause dangerous rebound hypertension. Any adjustment must be supervised. Second, do not dismiss symptoms like fatigue, brain fog, or frequent dizziness as simply getting older without asking whether your blood pressure treatment could be a contributing factor. Third, do not assume that lower is always better. For your age group, the goal is not the lowest possible number. It is the right number for your specific body. Within 1 week of monitoring at home, you will have a clearer picture of your actual daily pattern than any single clinic visit provides. Within 2 weeks, you will walk into your next appointment with specific data and specific questions. Within 30 days of an appropriately individualized treatment plan, you may begin to notice differences in your energy, your balance, your mental clarity, and your quality of life that you had attributed to aging and accepted as permanent. Your body is not broken. In many cases, the information guiding its treatment is incomplete, And now yours is more complete than it was 30 minutes ago. So we have just gone through 7 critical things you need to understand about blood pressure after 60. We covered why the 120/80 target was not designed for your age group. We covered why the diastolic number matters more than most people realize. We covered how medication timing affects your mornings and your nights. We covered how white coat syndrome is leading to unnecessary prescriptions in seniors. We covered the nuanced truth about salt in older adults. We covered the specific risks of common blood pressure medications that are rarely discussed. And we covered the most important revelation of all. Your blood pressure target should be a personalized range, not a universal number borrowed from a different decade of life. My main message today is not panic. It is not distrust of medicine. It is empowerment. You now have information that most people in their 60s, 70s, and 80s never receive in a standard medical encounter. Use it, ask the questions, bring the data, advocate for yourself. Here's my challenge to you. For the next 30 days, monitor your blood pressure at home, record every reading, and bring that data to your next physician appointment. Just 30 days. Your brain will thank you. Your kidneys will thank you. Your independence will thank you. And remember, Dorothy, dancing at her granddaughter's birthday party at 83 after someone finally asked the right question about the right number. That is what this information is for. If you found this video helpful, don't keep it to yourself. Hit that like button. Subscribe for more real health solutions designed for adults over 60. And share this with someone you love who takes blood pressure medication. You might just change their life. And now I want to hear from you. What was the most surprising thing you learned today? Share your answer in the comments below. I truly want to hear your story. Because remember, aging does not take away your body's ability to thrive. It simply reminds you to care for it the right way. Take care of yourself.